Okay, and next up, our very own Daniel Glazar.
All right, thank you. Yeah, thank you, everybody. So, yeah, I'll be presenting work that I've done, my postdoc with Renee Brady-Nichols here, especially looking at patient-reported outcomes. Okay. Ooh. Looking at patient-reported outcomes, trying to predict clinical outcomes from that. And in particular, I'm going to look at feeding tube dependence as an outcome. I know on my abstract I said hospitalization, but they're basically the same thing. And well, not really, but in particular, I'm going to look at lung cancer patients treated with radiation. Okay, so in particular, yeah, we're looking at head and neck cancer. About 50% of all cancer patients are treated with radiation. Is the standard of care for head and neck cancer patients. And this is also coming from the IMO workshop that we had last year about focusing on toxicity. And so in this case, the patient comes in, they have an MRI. This is the planning here. And then 2 or 3 weeks later, they start treatment. And in this case, they have 7 weeks of radiation. Although I realize that in my simulations in a minute, I'll do 6 weeks, but and in particular, we have an issue of in the second half of radiation, we have acute toxicities. In particular, feeding tube dependence, and this is correlated also with difficulty swallowing. And so, how do we measure some of these toxicities that we're interested in? And they're measured by these patient-reported outcomes. And this comes in the form of a questionnaire that we have many different items or questions asking about symptoms. So, for example, in the last 7 days or 2 weeks or whatever, have you had pain in your mouth on a scale from 1 to 4? There's a Likert scale in that case. And then you can see some of them will be grouped together. So like these 4 are all involved in pain. The next 4 are all related to swallowing, difficulty with swallowing. You could have single items like, okay, there's a problem with teeth, problems opening your mouth, and so on. Okay. And this is some published data that we were considering, that we were looking at in the workshop. 859 head and neck cancer patients treated in Groningen, which I believe is the Netherlands. I forget. And this study was particularly focusing on longitudinal quality of life and toxicities. And so you can see what they look like when radiation is given over 7 weeks, and then radiation is taken off. And you can see over most of these measures, radiation, you have these acute toxicities, and then it kind of goes back down over time, right? In particular, if we're looking at this feeding tube dependency, and our question is, okay, how do we model now? This is, by the way, population data, but how do we model patient-specific, patient-reported outcome dynamic? Okay, so the way we're going to do this is using Markov chain models. So in the simplest case, we have discrete time and homogeneous Markov chain. So we have a certain number of states. So here we have, this is just an illustrative example. So we have 5 different states here, 1, 2, 3, 4, 5. And you have different probability of transition from time point I to I plus 1. Okay. And so we can model this using, by constructing this probability matrix. This is how it's defined. Probability of going from state I to J, right? Now, because patients, there's a lot of heterogeneity in terms of when patients will actually come in for to be evaluated and so on. We consider the continuous time case. And here, rather than modeling the probability matrix directly, we model a transition rate matrix. And so we can get this probability, state I to J, from now some continuous time S to T with this Kolmogorov-Ford equation. And so in our case, we're looking at 5 different states, 0, 1, 2, 3, 4, and they're ordered. So now we transition just only to adjacent states. And we have these rates, and that's what we're modeling now. And you can see, yeah, symptom goes up to the right and small, yeah. And in this case, where Q is constant, our rate matrix is constant. We have an analytical solution, which is just the as you expect, like it's a matrix exponential. However, we're considering especially the inhomogeneous case, where our transition rates are time varying, right? This takes care of a lot of the non-linearities of radiation going up, this transient increase, these acute toxicities. And so we can have some covariates like tumor burden, or which can exacerbate the symptoms going forward, or some like treatment or some symptom management treatments, like say nonsteroidal drugs. In addition, we in this case for radiation, I introduced this concept of radiation exposure, so that I'm going to get into now. Well, we'll get into in a minute. So some of the model outputs of this is we can get these transient state probabilities. So what's the probability of being in a particular state at a particular time? And here we have, say, for example, just this is all more theoretical, not really looking at particular data at the moment. So these are, say, 4 different patients. And in this case, I simulated tumor growth inhibition model that's doing this kind of U-shape dynamics, and they all have different dynamics. And this is the only thing that changes between them. But and just as a consequence of that, we can get different dynamics in terms of their toxicity profiles. Now, this is a lot to kind of take in at once. So alternatively, we can look at, say, the expected value of these transient states. And you can see that treatment, it goes, symptom goes down, but then evolution of resistance, the tumor starts growing again, and it comes back up. And additionally, we can then sample these distributions and generate data from this. And then for parameter estimation, which I'm not going to get into here, using like a Bayesian framework, we can go backwards now, or backwards this way, right? So now I'm going to introduce this concept of radiation exposure. Actually, idea I had with during my PhD with Heiko, that's kind of now materializing here, and I like to get feedback here as well. So this was inspired by pharmacokinetics modeling, where you have you have this drug exposure here. And it's a very simple model here. Just it's just like a bolus dose, and you have some decay, right? And we can solve this analytically, right? And that's just what it looks like. From here, we can we use this now as a covariate, a time varying covariate for our transition rate matrix, and this is what this looks like. So you have some sort of baseline hazard, say baseline hazard. So that's the Q naught, or the Q here, in the absence of treatment, and then you have this treatment term here for this radiation exposure. And so here, no feeding tube dependence. Here's feeding tube dependence. All right. You can transition back and forth. All right. And so we can simulate this model and get this transient state probability of that a patient is going to be on a feeding tube, right? And you can see that kind of shape going up and then down again, right? But what we're interested in is not necessarily just your probability of needing a feeding tube or not at a particular time, but more your survival probability, right? As a target endpoint. So really, we're interested just in this top right corner. So more of a first hitting time problem in this case. And this amounts to just a simple Cox survival model. And you can see as you increase the dose, your probability of feeding tube, goes up, your survival goes down, as expected, right? But now we have a model that can quantify this, and when we have data, we can parameterize. And so now we can consider some end tube as a function of dose, right? But then we can consider, well, what if we take the inverse and we consider our target toxicity endpoint tolerable dose. Now we can define this. How much dose can the patient tolerate now based on our endpoint? And then now this is work with HIP IMO, a student, a high school intern over the summer with Ryan Worthman, where we're considering as we could say, well, we can minimize this probability by just not treating them. But then, we want to treat the tumor, so we have to consider the tumor response, right? So now we're, obviously, as you're going to get, if you treat more with more dose, you have a higher response, but that comes at a cost of the toxicity. Considering this, the balancing of these competing objectives of tumor response and toxicity. So for tumor response, we considered the classical exponential tumor growth with linear quadratic tumor response. And you can see what this looks like as a function of dose. We have solutions for this. And then we can kind of do the same thing like that we did with toxicity. We can consider a clinical endpoint. Let's say at the end of treatment, what was their tumor size, their tumor burden? And our target clinical endpoint, what's the minimum efficacious dose that we can give? So now we have these two clinical endpoints. We can consider, well, is there a viable range of doses that we can give? And that's what we do here. What happened to, okay. Yeah. And so now we can look at this in 3D. And so now the patient says, okay, I want, with their clinician says, okay, being treated with radiation, I want this level of a tumor response, right? But at the same time, I'm only willing to risk this certain amount of toxicity or tolerate this amount of toxicity. And so they're going to be with their target endpoints defines a point in the space. And so now we can look at what's the range of doses between minimum efficacious dose, minimum effective dose, maximum tolerable dose, right? And we get this separatrix, where if we're in this region, radiation is not viable anymore. Okay. Yeah. And then we can consider now giving other sorts of therapies, like, for example, radiosensitizer, such as cisplatin, which is often used in conjunction with radiation in head and neck cancer patients. We consider, well, it shifts it down by increasing this alpha parameter radiation sensitivity. Alternatively, we can look at, say, symptom management drugs like NSAIDs or something like that, or a change in diet, behavior, things like this, that we were considering in the IMO workshop. And let's say this changes the, different parameters, so we can shift our suppression to the left, for example. So this is a summary of kind of the workflow, where we have this radiation treatment plan. On one, we have response and toxicity, right? And we get this separatrix here. This was, we just published this as a preprint, and now we're currently in the middle of doing some extensions to the modeling, considering not just a binary case, but polytomous, where you have 0, 1, 2, 3, 4, for example. Also toxicity trade-offs, that's something that we're currently looking at, and so on. Excuse me. So I want to thank you all for listening, and yeah.
Time for one very quick question.
You have oscillations, and I think I just missed the first time around
Where-
either from,
Why is this?
yeah, sorry, slide 8.
This is really. Go ahead. Yeah.
Thank you. On your graph, you have these oscillations, and I missed. So I'm wondering if you can say either from the point of view of the model or the physiology, where are those coming from?
That's coming from this this model I have for this radiation exposure. So where you give a bolus dose, it gives kind of hits the tissue, and the tissue then over time recovers over the course of the day. So that's what's going on here, right? So that's the idea. Okay,
you can ask
yeah.
the question, Heiko, but we're
Yeah.
Thanks. Hey, Daniel. Very cool stuff. I think you want to predict the risk of feeding tube dependency, and you built a model to predict this.
Yeah.
Have you told us about your accuracy? How good is the model?
We have not looked at the data right now at the
Okay.
yet.